We're back.
Hello.
I'll skip the usual. We need a theme song spiel.
Yep,
Welcome
we'll get
everybody
to
to
that.
Neurodivergent Normal. This is episode 5, and we're pretty excited because we're speaking to our first professional in their field tonight.
Yep.
We'll be bringing on Dan Houston from Connected Minds TMS. Um, Little background on TMS therapy. I've just finished it 2 or 3 weeks ago now. We'll let Dan sort of explain the ins and outs of how it works. But long story short, it's sort of for long-term treatment resistant things like depression, OCD, anxiety, a raft of other things. And honestly, I found it to be absolute sorcery.
Yep.
It was just magic. I don't know, obviously not. It's hard science. It's been around a long time, studied for a long time. It's just kind
Yep.
of picking up pace now. But man, I could not recommend it more highly. It has absolutely changed my life. So I'm really excited to speak to Dan.
Yep.
Before we get to that, how's your week been, Danny?
Yeah, it's been good so far, and yeah, I'm excited to talk to Dan tonight as well. I mean, I admit I hadn't heard of TMS until I spoke to you about it,
Yeah.
but it's the kind of thing where, so for tonight, I'm going to be playing the role of I guess the complete newbie who
Yeah.
is going to be asking the real entry level questions.
Hmm.
But I know, knowing you like I do, you're very much focused on what works and what's scientific and what's
Yeah.
what's effective and what's scientifically validated. So
Hmm.
yeah, and it's definitely, from the sounds of it, it's definitely seemed to be working for you as well.
Mm.
So I'm looking forward to hearing more about that. Aside from that, I've been pretty good. I actually wanted to give a shout out to. I was scrolling social media this morning, and I saw one of my favorite social media accounts at the moment, the Daily Tism, who you're probably familiar with. Okay, right. I recommend checking them out. They posted a like a story, like a satirical post that said, with a fake headline, it says, "Rejection sensitive autistic woman decides on career in the arts for some reason." And I had to share that because that, for me, that's so relatable. I mean,
Yeah.
I've made music, I'm doing this podcast, I'm trying to write novels at the moment.
Yeah.
And like growing up, I was always, I feel like to an extent I did experience rejection sensitive dysphoria. I mean, I would I would hate it. Whenever I felt like I'd been misunderstood, it felt like the world was ending to me, and I was always I would rush to explain myself because I couldn't handle people misinterpreting what I felt I meant, and getting the wrong idea about my intentions. So it's kind of interesting that I'm doing these artistic projects now, like writing novels, which are by nature ambiguous. I mean, that's the thing about art. It's up to multiple interpretations. So maybe that's what I need. Maybe I just need to subject myself to the scrutiny and the criticism of the public in order to overcome my rejection sensitive and also people pleasing tendencies for good.
I had a friend asking me the other day for someone they care about, is that a thing and how do you deal with it? And I said, well, yeah, it's a thing and it doesn't really go away. I just try to practice more mindful communication with people.
Yep.
So I still catch myself, getting pulled aback a bit sometimes when someone says something, but I stop myself when I catch myself. There's always we can't change our brains. There's always a failure rate built in, but you can at least try to be mindful and build tools to deal with these things better.
Yep.
I was watching I wish I could remember the Instagram. It's an English guy who talks a lot about ADHD. It reminds me a bit of you. I think I've
Oh
said
yeah.
it before. Same mannerisms and stuff.
Yep.
But he was speaking to this doctor, I believe, who was saying, there's nothing abnormal about being hypersensitive to criticism as an autistic child or an ADHD kid because, people will criticize an autistic child for playing with their toys wrong. And
Oh.
something along those lines. And he said, and if they will criticize them for that, imagine what else they'll criticize them for. And so they spend their whole
Yep.
life being criticized being told not to be who they are naturally because who they are doesn't fit the mold. And so, of course, you know, you grow up because you never expect it when it's coming. You don't know that's coming. You don't know why it's happening. It just sort of happens. And so, of course, you kind of grow up just always waiting for the next criticism. So it's something that just happens, and you kind of have to teach yourself to stop and think and try and catch it as often as you can and just think through what's being said. Which isn't easy, but
I saw that video. That's Pete Wamby.
That's the one.
Yeah, he I love Pete Wamby. His book Untypical I really liked. And in fact, Pete, if you're tuning in, would love to have you on the show sometime.
Absolutely. Yeah.
So but he's great. And I mean, I saw that video and I agreed completely. I mean, it was one of those things where growing up, there seemed to be no real rhyme or reason to it. I mean, if anyone hurt my feelings, it was always, well, you know, can't you take a joke? It's just banter. That's what people do. They banter. But, you know, I would say something that I wouldn't even think was a problem. Like, and suddenly, like, the whole room would, you know, this sort of awkwardness would fall across the whole room, and suddenly I'd be persona non grata. So, there seemed to be no logical consistency to it.
No, and the other thing is to take a joke, you need to understand that it is a joke in the first place, which is not always the case, you know. I think I still have shocked some friends who've known me for a long time when they realize, that was an obvious joke, and he's just completely taken it literally, and now the conversation's over here. I think like I don't want to paint this negatively at all, but I think, you know, the best thing you can do if you have an autistic friend is to never underestimate what might go over their heads. Because you may be a little shocked. I've seen it sometimes. People are genuinely shocked. They're just like, they can't comprehend how that could go over your head. But it's like, well, that's because you're not autistic. So just trust me, it did.
I mean, for years I didn't understand, because my grandmother had a saying, speaking of taking things literally, my grandmother had a saying when something was expensive, it's as dear as poison. And it never made sense to me. I was like, well, poison is really cheap. I'm pretty sure you can get like some floor cleaner or something for a few dollars. But and then someone explained to me that means it costs you your life. I was like, oh.
Well, I can't, forgive me if it was here. No, it wasn't here. I was watching a different channel, and they were talking about, the guy was talking about how someone had finally explained to him at 40 years old what the chicken crossing the road joke actually meant, like to get to the other side, meant because the chicken would die. And I just thought my whole life until a few days ago when I watched that it was like just a silly joke with a not really funny answer. I never, like 40 odd years of life, and I never got the joke until just now.
Yeah, I thought the same thing. So it actually it has a double meaning then, like the other side of the road and also the other side of life.
Well, and what's funny is it was like when I was a little kid, I thought it was funny because it was silly, and it was like my most told joke as a kid, and I still didn't get it until now. So anyway, we could go on about that for a long while. We may actually, we've spoken a little for anyone out there about maybe towards the end of the year doing a recap episode and getting a bit more into our own lives if we're feeling up to that towards the end of the year. But for now, we're going to get Dan on this. So let's bring him in. Hey Dan, how you doing?
Hey Dan.
We can't hear you.
I've got a bit of a delay as well.
Oh, there we go.
Oh, okay. Can hear you now?
It'll even up. It'll
even out. So Danny, in that introduction, did John leave me a lot to live up to, or we set the bar nice and low so I can impress, or how'd that go?
Well, he gave just enough information to entice me and indeed the listeners to want to know more. So it was just enough information to be intriguing, but it didn't give the whole thing away.
Cool. Nice.
I did also say we're speaking to our very first professional in their field, so
okay.
Yep.
And so there's the pressure for sure. Yeah.
I think
So
we're speaking to our very first non-musician as well. I mean, I don't know that for a fact, but
yeah,
we don't have a song to play for you. We've had a
yeah,
song for
which
everyone
is
else.
great because I fucked it up nearly every episode. So
you
But,
you might have songs I don't know about.
yeah, yeah. I don't know if you've ever been in a band. We're happy to play it and add it later if you want.
I can play a little bit of guitar around the campfire,
Yeah,
bit of Bob Marley
Yep.
and stuff, but I'm not really.
Oh yeah,
Yeah.
yeah, yeah.
all right. Well, let's get started. So, Dan, do you want to just tell us a little bit about yourself and sort of how you got into TMS therapy and started Connected Minds?
Yeah, cool. So, I mean, I've worked in health in all sorts of different fields for quite some time. I started my first degree was, a Bachelor of Science, which I sort of moved into a psychology stream in, and then realized how long that would take me before I could do anything. And I moved up to Townsville, and I was actually, I started doing nursing up there, but I joined like the Army Reserves. And my thought was, I was like, I had a friend I played rugby with who did tours over to Afghanistan with the reserves as a nurse and ICU and things like that. And he actually worked for the DPP as a lawyer as well during the week. So we had two government jobs. So I found out that they would actually, government jobs would pay you while you still went on deployment. And I thought, well, that's a
Yep.
good way to make some money and I can come back and
Yeah.
maybe go back and sit down and do med. And I started off in critical care. So I started off in like ED, CCU, ICU, and I hated it. I was like, this isn't for me at all.
Yeah.
So I sort of decided I think I might want to go back and work in the mental health field. And I was like, well, let's give that a go because it's the first thing I sort of tried. So I got a position as a CNC at a drug and alcohol rehab. At the time, it was ADFQ, which was the Logan House, which is now under the auspice of Lives Live Well, which I'm sure plenty of people are familiar with Lives Live Well now. It was only a few rehabs back then, but now it's like massive. It's got all sorts of different places with it. And I stayed there for a few years. And when I started there, I was like, I'm actually going to go do law and I'm going to leave health. So I did
Oh yeah.
law for a little bit. And then I started really enjoying what I was doing. I was working with people, case managing at the drug and alcohol rehab. And I started doing my masters. So I did my masters in mental health. Moved into an emergency role probably a bit over 10 years ago with Queensland Health, where I worked in emergencies around the place. So I was working in the emergency department doing psychiatric assessments for people who came through the door. I ended up working as the co-responder to the person who goes out with the police in the ambulance to those sorts of situations. And I spent a lot of time, I ended up sort of, I guess, suppose being the CNC there. So running the flow through emergency with, with the people who are presenting with mental health issues. And I got to see a lot of we can't help you, basically is a lot of the time. So there's a lot of people who are only, who maybe don't quite meet the criteria for the threshold for even being seen by a psych reg there, like a doctor will refuse to see them. But I'm like, well, hey, listen, you can go and see this person. I've done a full assessment. You could potentially try and put them on antidepressants and send them back to the GP. With that, they'll be like, no, we're not doing that. That's some role in here, blah, blah, blah. So, we have that sort of thing. You might end up with the other end of it where you've got, people who are well known who present a lot, and the psychiatrist is like, we're not admitting this person. So there's a lot of it's pretty hard work over a period of time. It becomes quite.
Can I just ask, was that more of a bureaucracy thing or more of a budgetary thing or a mix of things?
So there's a mix of things there, I suppose. So there's that idea of first do no harm. Sometimes if you're admitting people over and over again, you're potentially reducing their ability to build resilience against things as well. That's the other thing. We can find people who become institutionalized by being admitted too much. So there is that. There's also the constraints that there isn't enough room to take everyone. So if you've got the psychotic person in there who's potentially been brought in by the police because they were trying to stab someone with a knife, and then you've got someone else who's presented 5 times that week who's threatening to harm themselves again, and there's only one bed for that person, they're going to end up obviously putting the person in who's, psychotic over that. So there are obviously, constraints on the resources available when you go to an emergency department. That's obviously the wait times, all those other things like that. And there is a lot of bureaucracy around that stuff too. So it's like, how much paperwork do you have to get done? So everyone's like, oh, I'm going to have to wait 3 hours for a review, but that's because the clinician actually takes 3 hours to see someone because they've got to do 2 hours worth of paperwork to see every person that they see. And you can't use AI to do your notes. You can't do any of that sort of stuff. You can't dictate it on certain programs. You can't. There's no way to make that faster. So, it's a situation that, like, obviously people get quite frustrated to be in. And as a clinician, it's very difficult to work in that because you start to become quite jaded over a period of time. Like, by the end of my time, I'd start to get a little bit like, I would, you get into that stuff because you want to try and help people out, but the small amount of people that you're helping out, or, occasionally you might get a win, but most of the time it's very thankless. People are mostly pretty abusive towards you because you're delivering messages they don't want to hear. You're stuck between a rock and a hard place really because you've got, like I said before, you've got those constraints and bureaucracy, and then a psychiatrist saying, no, we're not going to do that for someone. You're the one who has to deliver that news. So, I did that for a long time. It's like, you do public service or whatever. That's why it's called public service. And I established there's a real need for services that are accessible and available to people who don't meet that threshold, who don't need an admission yet, who are still struggling in life, but the GP hasn't quite got anything for them either because of like, they've tried, someone's tried therapy, they've tried a couple of medications, and I guess the evidence isn't great around trying another medication after you've already tried 2 antidepressants. Your chances of that working are about 10 to 15%. So it's pretty low. Whereas, I knew that TMS worked and I was like, well, cool. So we'll start doing this.
So how did you come across it exactly?
I'm working through private hospitals, talking to people, working through private, many years ago, doing shifts through private hospitals, having talks to people who had been doing it. And just talking to people within the space who I knew had it previously, and what their experience was with it. I didn't quite know how many people I would see get much better, but it does really end up sort of being very much what the research says, which was, your 50 to 60% of people having a really good reaction to it, which is awesome to see because you don't usually see, it doesn't matter whether you're doing case management, whether you're working with someone individually with psychotherapy, usually you don't see someone within sort of 3 to 4 weeks get that much better. It's crazy to see. So, and it's awesome. Like, there's people who've made me teary with their stories before, and just seeing people get better, it's a really rewarding space to work in from that perspective.
And are there some people, sorry, Danny, are there some people, so you say like 56% of people get really good results. Is there more on top of that get some results but maybe need more treatment?
Yeah, so the statistics say, right, so the statistics, there's a really, really large, and I can't remember what the paper or research, group was, but it was about TMS, about the different modalities, right? So they had like psychotherapy on its own initially, psychotherapy with medications. So, the response rates initially for psychotherapy with medications is about 60% of people. You'll see that they'll actually get better with those two combination things as a first line treatment.
Yeah.
Once you start going just, I think medications on its own was a little bit less than that. And then the second medication was like about a 20 to 30% response rate. And by the time you get to third and fourth medication, you're looking at only sort of that 10 to 15% of people potentially getting better. In that same cohort of people, so you've already got people who have tried psychotherapy, who have tried medications, that same cohort that are unlikely to respond to antidepressants. If you just give them TMS on their own, that the research showed that they had a 50 to 60% response rate. And that response rate would have been, it's big. So that response rate would have been measured against, I don't know what their exact measurables were, but it said remission. So, probably reasonably good. You would say that, I guess the information that I've been told outside of this when I talk to, other researchers who are head of global education at other big multinational TMS companies and things like that, they've said you'd see roughly 80% of people get about a 30% reduction in symptoms. But we would say that a 30% reduction in symptoms can probably be down to other factors, like you got to bed it, like someone who's depressed, like, you got out of bed 5 days a week.
Yeah.
You went and saw someone. They asked how you were.
Because 35 sessions every weekday. until that's done. Yeah.
Exactly.
Yep.
So, Danny, you were going to ask?
Yeah, just to I wanted to bring it back to the real basics here. What is TMS? I mean, I saw it. It stands for Transcranial Magnetic Stimulation, I believe, which gives me some idea. But how would you really break it down into layperson's terms?
And tell us how it's not shock therapy, because people keep asking me that.
Okay. So TMS and ECT are only similar in that you both describe them as neuromodulation techniques, basically. So in TMS, and I'll describe TMS, we're taking, a scalpel to a problem, whereas ECT takes a sledgehammer to it. And I'll explain the two differences. So in TMS, what we're doing is over a long period of time, we're sending an electromagnetic pulse into an area of the brain that it depends on what condition we're treating. Let's just say we're treating depression. Into the dorsolateral prefrontal cortex, which has to do with executive functioning. It has to do with, emotional regulation and a bunch of other, things that can potentially help with. And we're attempting to activate those underlying neurons by stimulating that exact point. So we measure up that exact point, we put the coil on someone's head, and then we shoot a pulse into that for about 20 minutes. And that's 5 days a week. What we're trying to do is, obviously TMS is over, 35 sessions initially, because we're trying to make those changes at a neural level. And changes at a neural level generally do not happen quickly. Now, there's all sorts of other people who'll go out there and try and give you all sorts of other protocols of twice a day and all this other stuff. I understand that people do it and they do get a response to it, and I'm not going to hoo-ha what other people do, but to me, it's when I'm thinking of things rationally, I'm like, well, if we're trying to make neural changes in someone's brain, if you want to change a habit, for example, how long does it take to change a habit? Generally, sort of 6 to 12 weeks. We're changing neural pathways, so what we're trying to do is, and it's in a specific area of the brain. So
So it's like rewiring the brain, like neuroplasticity.
Yeah. So essentially, So we're working with neuroplasticity, I suppose. Yeah, that's what we would say. So if someone doesn't respond to the right side, anyway, I won't go into all that. We'll stick with the very.
No, please dig into the weeds.
So we do psychometric testing. We do like DAS-21 and Beck Depression Inventory. So we give people questionnaires before they start. We do it at session 10, 20, and 30. So this is how we can give a numerical value to what is actually happening and whether the person's responding. And that gives us a graph at the end. And we'll go like, the BDI looked like this, the DAS looked like this, the scores went down. So that's how you can say, hey, listen, there was a value put on what this person's scores were initially, where they were at session 10, 20, and at the end. And you can go, hey, listen, sometimes anecdotally, people say, I felt hits better. And I look at the scores and it's a flat line. And I'm like, okay, well, your scores said you're on a flat line, but you've said this, so I'll write that in the letter to your GP. And they're still happy. And I'm like, okay, cool. Well, if you're still happy, that's fine. But your scores didn't really say that. If we see partway through the therapy, the scores aren't coming down, we would change to a different protocol. We've got a couple of different options for that. I won't go into all the protocols right now, but we would change the area of the brain the side of the brain that would be stimulating. So, but that's like TMS, right? So you sit in a chair, you've got a coil on your head. It's generally relatively painless. Sometimes there's a little bit of discomfort in the first few sessions because it's tapping on the scalp. There's obviously, you've got nerves on the scalp that sort of become desensitized in that area over a few weeks for the pulse going in. Sometimes, it's particularly people, I'm not sure how often Kev doesn't wear a hat in here, but particularly people who don't have, Danny's lovely set of lovely locks to get in the way, to get in the way of the pulse sometimes.
Your helpers at the clinic would get a little annoyed at me because they draw the dot and expect it to be there the next day. But with me, being bald, it was just I would wash it all off in the shower.
Follicles, it won't catch.
They'd have to remeasure me every day.
Yeah.
So
Yeah. So sorry, do you want me to talk about ECT and what ECT is instead?
Why not? Let's get a little into that.
I'll do ECT really quickly. So TMS, you come in here, you can drive home afterwards. There shouldn't be any, negative cognitive sort of side effects or anything like that. Sometimes you'll have a bit of a headache. Most common thing is a little bit of pain locally, a little bit of a headache, usually for the first few sessions. Most of the time that doesn't continue onwards. ECT on the other hand. So ECT needs to be provided in a hospital setting. It requires sedation. an ECT, they induce a seizure, and they'll either do both hemispheres or one hemisphere of your brain, depending on what they're trying to do. So this is what I mean, like, they're taking a sledgehammer to try and reset the neural networks and pathways in the brain. They're inducing a pretty severe seizure. That comes with a bunch of other stuff. So if you see people who have had ECT multiple times, especially when they become older, their fine motor skills are reduced. Their memory is usually pretty bad. A lot of the times they get early onset dementia. Directly after ECT, if you see people in a hospital setting, they may be sitting there drooling, not knowing where they are. They may urinate themselves. There's a whole heap of, it's a pretty severe. Now, I'm not to say it doesn't work, because it does work. It is quite effective with what it does a lot of the time. But for me, I'm only ever recommend it to people where there's no other choice, where, like, you've tried absolutely everything. In my belief, it should only be used for people who are potentially like catatonic, but even then high dose benzos is probably better to start doing that sort of stuff. Or potentially there's psychotic symptoms that haven't been resolved through using antipsychotics. That's my personal opinion.
I only have the layperson's understanding of electroshock therapy, so I'm probably wrong. But it seemed to me, once I discovered TMS, that TMS was to electroshock therapy what electroshock therapy was to lobotomies. You know what I mean? An advancement, much less invasive. You know?
A little bit.
Yeah.
Can't, like, a lobotomy does a little bit more than ECT, but as ECT does a little bit more than TMS potentially. But we're cutting out all the really negative stuff. So
unpleasant parts.
Yeah.
What are the main conditions that TMS treats? I did see when I was doing a bit of research, I did see quitting smoking could be one of them, which made me wonder about other potential addictions, whether it's helpful for those. But obviously things like anxiety, depression.
Yeah. So it's interesting you're talking about. So anecdotally, again, this is not something that I measure. I don't measure substance use people. I don't do that. But I've had so many people go back to, particularly, I've had conversations with Lives of Well. I've talked to their staff because I've found a bunch of people who have come in, particularly with smoking weed, who have gone, I don't need to smoke weed anymore. They're like, and it's usually in the first week or so. And they're like, and it's kind of like, well, we're working on an area of the brain that's related to impulsivity as well, impulsivity, emotional control, and regulation. And it's kind of like, what came first, the chicken or the egg? Was it because we're helping treat the depression and anxiety so you don't feel like you need to do it? Or are we actually doing something a little bit different around this impulse control and regulation when you're taking time to stop and think, do I need to do this really right now? And this was just a habit that I was doing. I was just picking up and smoking, 4 bongs every night, but do I really need to be doing that? And why am I doing that? It's not making me feel better. Or, what part of that comes first. Anecdotally, I would say the best response, I've seen really good responses with people who have, now I'm not out there preaching as, this is not like something that I've got evidence on. I'm like, they're going, oh, hey, listen, you should come in to get it for substance use or anything like that. But it does seem to be something that I've seen quite a bit. Conditions, look, I had someone who had vertigo. It was like anxiety-related vertigo that really helped that person. They haven't had whether it was the anxiety or the vertigo, whatever came first, it seems to have really helped them with that. But, anxiety, PTSD for sure. I certainly have people under DVA who come through for PTSD, so a lot of veterans. Depression, it has level A evidence for depression. So we can say that 100% there's evidence to say it's really good for treating depression. Level B evidence for things like anxiety, PTSD, and then there is levels of evidence with regards to those other things that we've talked about, like substance use. People say tinnitus. There's OCD and there's a bunch of other conditions, but there's, with TMS, it really depends on the area of the brain that you're trying to affect and stimulate. So we know that all these different conditions, potentially originate, or potentially there's potential dysfunction in certain areas of the brain that contribute towards these conditions. Even people will use it for chronic pain. You can use it on the contralateral side down the motor cortex to help with complex regional pain syndrome. So there's a few other things. You can use more powerful machines, there's people using that on, you would almost say nerve complexes to help further down the line with pain as well, but that's directly to the skin. So there's a lot of different things that people can use it for. Primarily, we work for depression and anxiety here. You're muted.
Oh.
You're muted, John. John.
Yeah, John. You're,
You're gone.
yeah.
Sorry.
So
I'm here now. You're back.
Okay. Well, yeah. So I was pointing at my beer, putting it in front of the camera while you're talking about people getting off substances. They see me scull a beer. It's non-alcoholic.
Yeah.
But that was generally like I started drinking a lot less during, and it wasn't like a conscious thing. It just kind of happened. And then after the sessions finished, I was just like, oh, I think I might have a month off. And that's what I found most with the treatment was these things got better, but I wasn't even conscious with a lot of it. I mean, I was conscious that I was having it, but like I just remember waking up a few weeks into treatment going, my anxiety is not less, it's gone. Like it's absent. Because that was really a huge problem for me. It was really crippling. And I was just like, wow, this is amazing. So I'm interested in, you talk about the neural pathway side of things. Because it's kind of like my brain changed. It's not like you zap me in the brain and tell me don't do that. It's like everything just gets better, and I don't fully understand. Like, do you understand much about that deeper part of it, about why it tends to change behavior?
So, well, I've got to be careful here because I'm not a neurologist, and I'm going to probably fall over my my words around trying to do this. We call it the central executive network is sort of so some of the pathways, some of the deeper pathways, the ACC, the central executive network. What we're really doing is helping promote activity between deeper areas of the brain and the prefrontal cortex. The prefrontal cortex is where you will make all your decisions, right? That's your conscious thought. That's where your behaviors. When someone has damage to their frontal lobe, because we talk about you talk frontal lobe, right? When someone has damage to their frontal lobe, it results in personality changes, aggression sometimes, all that sort of stuff. So I'm not sure whether or not you guys have ever talked about people with ABIs and, you've had a conversation with someone who's got an ABI who, now has trouble with, their impulse control and they've become aggressive very easily or anything like that. These are the sort of changes and those are the areas of the brain that we're promoting connectivity between. So, I guess I won't go on. There's two different theories about how it works. So one theory is that we're promoting stimulation between those two areas. The other theory is that we're actually disrupting the network there and causing new neural pathways to be formed in the area that we've been pulsating, we've been sending pulses into. So that was something that a neurologist that I talk to sometimes who runs I run the training for TMS through I'm actually doing one on Saturday, but I run the training for psychiatrists. So we train the psychiatrists and the other nurses and clinicians and stuff. I'm involved in providing that training. So the guy who runs that is a guy by the name of Dr. Trevor Brown. He works for Neurocare Academy. He's the global head of education there. He's maybe someone who would be willing to do the podcast with you and potentially answer the nitty-gritties and things when you want to get down to
that'd be great.
Yeah.
Pass on along our details. But it was bizarre because it didn't feel voluntary, but in the best kind of way. Like I just felt better and I made better choices, and it was the strangest, best thing that ever happened to me. I was just like,
that makes me so happy. I love to hear that.
Yeah, so good.
John, how did it affect your emotions in any way? Did you have more emotional range or just calmer?
I've been saying I can have an emotion now and it doesn't have me for breakfast. My emotions were so all consuming, taking into account that, I would sort of swing back and forth between clinical depression and severe autistic burnout, which was where it's much more extreme because your emotions become so much you just melt down and you're essentially I don't say this in a judgmental way, but you're like an emotional toddler at that point. You're not thinking. And this kind of speaks to what you're saying, Dan. It's like your frontal cortex is no longer regulating. It's all lizard brain at that point. And that just kind of went away. I was able to handle things. I was able to socialize more. I found I could communicate better. My brain fog was gone. Weirdly, and I don't know if there's any data on this, but I found that my task paralysis from ADHD just disappeared. I had like some of the most productive weeks at work that I've ever had in my life. So
Oh,
yeah, I
wow.
mean, this is all anecdotal. I don't know what the research is on this stuff. I do know they just came out with a study on autistic children from 4 to 10. I won't go into it because I can't remember where it is or point anyone to it, but showed improvements in communication and stuff like that. So I know it's sort of being looked at. I know Lawrence, who works at the clinic, was involved in a study with children, autistic children, and improved sleep through TMS.
Yeah, so
It
they
showed
do.
some
Yeah, they
promising
do
results.
it through NDIS, and
Yeah.
there's a NDIS funded. Usually, they do. It's called Brain Treatment Center. It's at Morayfield, and they
Oh,
almost
yeah.
primarily they do almost 100% just kids with ADHD and ASD. Yeah.
Mm. I'll give you a little last anecdote, Danny. There's a song called
Yep.
"Nutshell" by Alice in Chains,
Yep.
and if I've had a few beers and that song's on, I'm in trouble, right?
Ah,
But
right.
then I found a few weeks in, it was Friday, I chucked it on after a
Yep.
few beers just out of habit, and I was just like, wow, this is a really beautiful song. I was like, oh, I love that guitar part and those vocals. It was just, that
Mm.
was the moment where I really went, shit, this has changed my brain. I'm
Yep.
like, I'm just appreciating this song for being a beautiful song, whereas it used to be the thing I would put on when I was like in a dark place, you know.
Yep.
Um, so
Mm.
yeah, it allowed me the space between me and my emotions. It wasn't so noisy up here.
Yep.
I could, and I have a personal theory. I don't have no idea if it's correct, but being autistic, we don't just struggle to understand other people's emotions. We struggle to understand our own. And I
Yep.
felt like having that extra space up in my brain um, made it easier for me to recognize my own emotions and manage them because I could sort of go, oh, there's that one, and organize my thoughts
Yep.
instead of just having them all overwhelm me all the time.
Yeah, definitely. I'm no stranger to autistic meltdowns, and sadly, once I get in that state, I can say things that I just don't mean or that I
Mm.
regret saying later on. Not lashing out at other people really, but just making statements that I'm like, okay, I wasn't thinking clearly when I made that statement, and
Mm.
I don't actually feel that negatively about the thing that I was melting
Mm.
down about. Like it's, well, sometimes in that state I can kind of blow minor inconveniences up to catastrophes
I,
because,
I,
like,
I tend to do that on Facebook, which is very unfortunate.
yeah, yeah, yeah.
Yeah, but I haven't had a meltdown since I started treatment.
Oh yeah,
I don't expect that I never will again, but I just feel space between me and what I'm feeling and what I'm thinking, and it's just allowed me to remain positive and see more clearly if I'm doing something that's burning me out, and pace
yep.
myself. And anyway, sorry, Dan, we're getting a little carried away.
It's fine. This is some sort of like a brain incident or anything like that. This is like
I was gonna say exactly that. Did you just want to tear it out?
I had a little bit of like kind of biopsy done on a little thing. The
Oh.
skin person was like, oh, I'm not sure what that is. Cut it out then and go and find out. So yeah, I've got a that happened yesterday, so I've got a little thing on
Okay.
my face.
Yep.
But yeah, it's not an eyebrow ring incident. And it's medical.
Yeah, that's why I'm scared to get my skin checked because they always seem to be like you have lots of suspicious looking moles.
I just take,
You have more.
I'm a cut it out person. I'm like, just cut it all out. I don't care. Cut it out, send
Yeah,
it off.
I tend to be like that. They're like, we don't. They're like, oh, we don't know it's dangerous. I'm like, I don't care. Get it
Yeah,
out.
yeah,
just take
me
it out,
too.
whatever.
But they're like,
So,
oh.
so we kind of, I guess we've kind of been over who a good candidate is, but could you maybe just run through? I've had questions from friends who want to know more about like the process for how you get approved for it and what may or may not make a good candidate.
Really hard to say what makes a good candidate. I've had
Mhm.
people who have come through the front door who have pervasive depression, and I'm like, this person is like, you see them, it's their body language, they've got that, that whole slow psychomotor stuff going on. Their voice is monotonous. You're like, wow, this is really going to help. this person, nothing happens. I've had that happen. And then I have other people who come in like, I had a guy who was, he had very obvious, he was very obviously autistic, but quite high functioning. He was like he was like managing he worked for an NDIS company, managing a bunch of different cases or whatever else. He was like a case manager for NDIS. Very obvious, amazing response. And almost straight after the first week, his wife was like, this has changed my life. This has been amazing. I'm going to send, very similar to, what you sort of said to me. And when I engaged with this person initially, I was like, well, it was obvious that they had ASD, but it wasn't like, their depressive symptoms weren't particularly obvious.
Are we talking about me or?
No. Very similar to that. You know what I mean? So some people I see that pervasively depressed, and I'm like, this is gonna really help this person. So other people, I'm like, you seem okay. Like, and then they're like, this changed my life. So it's really hard to say. Like, obviously, everyone's brain is different. Obviously, not everyone responds. Anecdotally, like I would say, people with ASD seem to react really well to it. From what I've had, from what I've seen so far with regards to the mood and what you're talking about before, executive functioning and all the rest of it. Yep. I need to start going to mothers groups, because women who have postnatal depression, but have had that postnatal depression, but then they're sort of like 2 years on and their sleep hasn't corrected and they're still depressed. You wouldn't call it like your postnatal depression is like when you're like, there's that hormone, like there's a certain range of it, but you would still call it like ongoing depression after the postnatal stages that a lot of women get. I've seen really good results in that cohort of individuals as well, really good results. But, to be honest, anyone who's like, so the criteria for being able to get Medicare funded bulk billed TMS is that you've tried at least 2 antidepressants, you've got a diagnosis of a depressive illness, and you've seen a therapist or a counsellor at least once. And that is half of the population of Australia probably has a diagnosis of depression, has tried, most of the people have tried at least one antidepressant. And, almost everyone's spoken to a therapist. So you're talking about 25 to 30% of the population. So, if you're in a position and you're like, hey, listen, I've tried all these things, I'm not happy with the way things are going for me. I'm like, well, kind of what do you have to lose, really? I mean, most places will have different, like our pay structure here is that I tell people, it's a $220 fee to see the psychiatrist. If that person's like, I absolutely cannot afford that, I'll talk to the psychiatrist, but sometimes I can completely bulk bill the whole thing. And we do that. We do that for quite a few people, because there's a lot of people. I mean, I've got people who are living in refuges, who have recently been homeless and have just gotten housing. Like, they don't have $220 to spare. So I never wanted money to be a barrier between someone getting treatment that I know could potentially help them. I don't like that. And both of my clinics now, and I'll eventually open a third one, probably over in under somewhere. Any of those places, I will only employ psychiatrists who are willing to potentially see people and forego that. That money goes to them. It's not my money. Well, I can't really just make those decisions. It's completely theirs. But, I don't want to work with people who don't have the ethos of like, I'm willing to give up a little bit of money to try and help this person who needs something, because this isn't available. You can't just get this through the public health system. It's not like we can say, hey, listen, you're on a waiting list for 1 year and you can get it publicly. You can't. If you really, really, really need to see a psychiatrist for free, you will see someone through the public health system, maybe, because sometimes they just deny it. But you will see someone eventually if you wait for long enough, most of the time, and you make enough noise.
What would be an example of someone who may come in and the psychiatrist may say, not a good candidate?
Look, if someone meets the criteria, we're always pretty happy to do so. But if someone comes in and we see their DAS, like their scores are really good, that they seem really functional, or, we're seeing their scores are good, the reviews happened, you're like, well, you're not really meeting any of the criteria for depression at the moment. The conversation would probably be more along the lines of, hey, listen, maybe we try this. There'll always be a plan from the psychiatrist that goes back to the GP. We're not just going to see someone and go like, hey, listen, we always talk to someone beforehand, so we'll tell them whether or not they meet the criteria for bulk billing treatment. Because if they can't do that and they don't have an NDIS or cover or DVA, it might become too expensive for them.
You can do it privately, right?
You can do it privately, yeah.
So it's more about preserving the Medicare funds for people who are really...
For people who are needing it at the time, So, like, you can do it privately. Like, people do it as well. Like, there's wellness retreats and stuff. So when you talk about, like, better executive functioning and things like that, people are already looking at it in a way that, this potentially could be an enhancement to what... I don't even need to have a disease process for this to be positive for my life as well. You don't actually have to be depressed for it potentially to be beneficial for you. You just do it if you want to get it under Medicare, really. And I wouldn't be telling you, hey, go use your Medicare funded stuff just because they meet the criteria if they're not in a position that they like, I don't want to talk people out of it too, because some people are like, I would like to try this and see if it works. And then like down the line, it's a very low risk thing to procedure and things as well. So, yeah.
I think it's good for people to know that. Sorry, Danny.
That's right.
Because, got to be careful how I say this because this will be on YouTube. But literally when I got into the first session, I was saying to Kev, the psychiatrist, I felt at the time, I said, it is a matter of time before I unalive myself. Like it is going to happen. I'm on that path. I'm getting really tired of fighting this. And I just could not be further from that now.
Yeah, that's awesome.
Just zero risk.
Wow.
But I still, even then, wasn't quite sure if I didn't know what the criteria was for getting in, so I was a bit stressed about that. So it's good for people to just know that if you meet those criteria, you're probably going to...
Yeah.
We had someone come through the other day, and they hadn't had too many antidepressants, but there was such a high suicide risk that we were like, all right, well, because Medicare will also be like, there's always like exceptions to the criteria, right? So the criteria of like trialing 2 antidepressants previous, there's a contraindication for trying further antidepressants. You can just forget about that criteria. So we had a young girl who was like, Kev was like, I don't want to prescribe this person I don't want to give them a prescription to try another antidepressant because they might take it and they might overdose on it. So for us, that's a contraindication. And like, we're like, well, we can also double this. Like I referred this person onto the public health system as well to be like, we're worried about you. We're going to refer you onto the public health system to get them to do their follow-up. But I was also like, hey, listen, this is a good suicide prevention thing for you at this point in time because we're going to get to see you every day when we're going to check in on you and be like, hey, are you coming to your appointments and all the rest of it? So, there is also that. I think that it's, if potentially the treatment doesn't work in the way that, John's talking about where he's had amazing results, there's still always that thing of like, we've got someone in here we're checking in on them for 7 weeks. And we're saying, how are you going? Like, genuinely asking people how they're going. Some people become friends with the chair next to them and go, want to arrange to go to a coffee or like whatever. There's, that sort of stuff.
Yeah. Cool. And John's results do sound amazing. I mean, that's an amazing turnaround.
They really are.
Do you have, what if somebody comes in who's, sorry if you might have covered this already, but if somebody comes in who's not sure if the treatment is right for them, do you have like a checklist that you can run through with them or an assessment process?
Yeah, so like everyone who gets a referral, so the GPs only have 15 minutes, right? They don't really know you very well in 15 minutes. Or like they might be your GP for ages, so maybe they do know you really well. But I usually don't get a whole heap of information sent through. So usually myself or one of the other 2 managers will call up the person and we have a conversation. So we're like, hey, listen, do you meet this criteria? Do you have any, because like some of the contraindications, we don't give it to people who have epilepsy because it can cause a seizure in someone who has epilepsy, so we won't do that. So we'll ask someone, do you have a history of epilepsy or seizures? Do you have any medical implants in your head or your chest? Do you we'll ask all these things to find out whether I don't just like go, here's a GP referral and then flick someone straight to the psychiatrist. Now, some clinics probably do that. They just get a GP referral, they send it off to the psychiatrist and like, here's your appointment. We don't do that because I wouldn't want to waste anyone to waste their money or their time. Generally, we'll have a pretty good picture. Like, I would say very, very, very rarely do we have anyone who's been unsuitable for treatment. And probably I've maybe had probably less than 10 people for the entire time we've had these clinics going for a year and a half or whatever. Less than 10, probably less than 5, or maybe about 5 people. And I would say out of those 5 people, where the psychiatrist has said, listen, we're not going to do anything, it's been because the person has higher needs. One of the girls that we were going to do it with had a history of schizophrenia and was currently hearing voices about harming herself and her parents. And we're like, that's a bigger problem than giving someone TMS, so we need to send that straight to the mental health team. This person's just moved up from interstate and they don't have a mental health team around them and all the rest. We need to organise this. That's not suitable for TMS. Like, I'm not going through this person's I've gotten all the history about their negative symptoms of depression and stuff. But in my screening, I didn't ask them, are you hearing any voices or anything like that? So usually part of my screening process. So when they've seen the psychiatrist has picked this up on his review. We had someone the other day who was engaging in regular self-harm who hadn't eaten for 5 days. And we're like, you need to go to the hospital. Like, we can't just we need you to be more stable. We can do TMS with you later. We need to have you more stable before we can start the process. So, like,
it's sort of TMS is a realistic miracle.
Yeah. Yeah. Well, it's more like when the psychiatrist sees a need higher than something else, like, is there that immediate risk right now? Is there, something else that we need to deal with right now? They'll address that first. It's not to say, no, you can't come back and get TMS. And usually the person only has to see the psychiatrist once, because the psychiatrist will put in their notes, hey, when the person's in, like, a little bit more stable, maybe I'll do a 5-minute review with them. We won't charge for anything like that. We'll just say, cool, you can have treatment. You know what I mean? Like,
if I could just come at unsure from a different angle, someone who's unsure from a point of view of, I have to admit, the first time I heard about it, I'd never heard about it before, and I heard magnets, and I'm thinking, woo, right?
Yeah, that was my reaction as well. Magnets, how do they work?
You're thinking sound healing, you're thinking...
it just sounded like that.
Yeah.
But, I looked into it, and it's proper science. I don't know, if I recall correctly, it's been around since the 80s. It's been studied extensively. Results speak for themselves.
Yeah, so it's been around since 1985. They made the first sort of one where they were just doing singular pulses. And shortly after that, I think that was in like Sheffield in the UK or something, at a university over there. I can't remember what the machine was being made for, sort of shortly after that. So, like, it's been in mainstream sort of treatment centres, mostly in Europe and the US. We're a little bit behind over here in Australia. It's actually incredible that we've got any level of public funding. US and Europe didn't have any of that. Like, it's all privately funded for people who have enough money for private health insurance. And there's so many clinics in the US and in Europe and all the rest. Whereas in Australia, it's relatively, they had the one public TMS clinic I know about that they tried to open, which was, probably 5 years ago or something now. It was in Logan. And they had a wait list up to 8 months within like a couple of weeks. And so they just shut it down. We did. It's like,
why do you think it's popping off so much now? What happened? Because it's like people don't realize it's been around so long, and it's just it seems relatively recently that it's really. I mean, it only got onto Medicare late 24. Is that right?
Yeah, so it's only been a couple of years on Medicare for that thing, and this is the other problem. Like, we've got the 35 sessions, which can help. I'm hoping that, like, when I see people like you have good results. I have had people who came through for the first lot of treatment over a year and a half ago who have still been in contact and been like, this has changed my life. I still feel amazing. So you do see people that get better for, years. You see people who get better for months as well. That's the other thing. So, like, unfortunately, unless people get out there, and this is what I tell everyone, I'm like, hey, go right to your local member. I can't go and write to these people and not be like, hey, we'd like to get, what are we going to do about Medicare funding for more sessions for TMS? I can't afford this, but it's helped me, engage in my life more. I'm now able to go back to work. Like, plenty of people who start moving, finding jobs and things like that while they're in the middle of treatment.
It saves lives, literally, not to overstate it. It saves lives, it changes lives. I mean, for me, it'd be worth the investment purely because of what a productive member of society people who get this treatment can become. So yeah, but yeah, I hope that mine lasts a good while. I think, am I correct? I think Lawrence might have told me you can get one 14-session follow-up after a certain amount of time.
15 sessions after 4 months for
After
maintenance.
4 months,
And if you're
but then
still
no more
going well,
medication.
you might want to save that for when you're 6 months or something in.
Yeah.
Yeah, until then, there's like, well, am I allowed to talk about your treatment? I was about to say what you responded to, but
Yeah, no, go for it.
yeah, okay, cool. So you responded to a left-sided treatment, right? So that's the left dorsolateral prefrontal cortex. We do a 10 hertz, 20-minute, basically. I think it's 3,000 pulses in that amount of time under that frequency. For people who want to get cheaper TMS, I've got it down to like $80 a session for a theta burst, which is like a 4-minute session. So it's a 15-minute appointment. So $80 is about as cheap as you're probably going to get it anywhere. I don't know about other people's private prices. I know that other places in the city charge people like $400 a session. Our full sessions are $165 or something, which makes it, relative.
Sorry, so you mean after the Medicare's gone, I can still come in and pay for it?
Yeah, you can still come and pay for it. And we could probably, because you responded to that left-sided treatment, we could try theta burst, which is the shorter one. And there's probably because you responded to that side, it's probably a pretty good chance you respond to that.
Cool.
We could even try it on your next 15 sessions and see how you go with that, because you could be like, oh, cool, I can come in for the cheaper option. Because outside of that, people either get like refunds, rebates through private health cover, but a lot of people are sort of forced to take out private health cover and then go into hospital for a month to get treatment, because that's a no out of pocket apart from the admission fee or whatever that is. So, it's difficult. I try to make things as accessible as possible, but obviously, you got to keep lights on. Yeah.
That's good to know, because that was the only bit of anxiety that I still have, is if this, if it becomes less effective over time and I can't afford more sessions, because it bloody works.
Yeah. So, were there any other questions that anyone like?
Dan, did you have any more?
I think I think that covers it for me. Did you have more questions? Or
no, I would just say, Dan, you should probably just let people know where they can connect with the business online.
Yeah, contact. Yeah, get in touch.
Yeah. So I've just got a new number. I've got a 1300 number now. So my 1300 number is actually 1300 000, so emergency TMS, which is 867. So the number for the place is 1300 000 TMS 867. So that's pretty easy to remember. But my website is just about to be updated. So when I started this whole thing, I started on a shoestring. Obviously, I funded everything myself. Loans from the bank and stuff. But I had no money to do things like build a really nice professional website. So now we've sort of gotten to the stage where the website is going to be updated fairly shortly. There is information when you go onto our website, which is www.connectedmindstms.com. Or if you just look up, apparently we're the number one search for like TMS Brisbane or something. You see something, there'll be an ad or something pop up on Google.
Oh, yeah.
In there's hyperlinks in the main, so they've updated my first page, but they're about to update a few other pages. But there's hyperlinks in there that go to evidence as well. So one of the things I didn't know when I first designed my own web page is that there's all these laws about what you're allowed to say on your web page if you're doing health services.
The APRA laws.
The APRA laws, yes, all the APRA laws, and
I know those ones.
They're too busy chasing down cannabis suppliers to work on TMS at the moment. So, I got told, and they're like, "Is this is your machines they TGA approved?" Because then there's another bunch of stuff you're not allowed to say. So they're making my website compliant, but they're also adding a lot of like information, hyperlinks to other stuff in there to sort of know what you're doing. If you want to get a referral to so there's TMS clinics. Like obviously I'm in Redcliffe and Caboolture on the north side here. There's ones over. There's a couple in the city. There's more towards the city, and there's a few on the south side as well.
I don't suppose you'd happen to know of any out Laidley way?
Laidley. Well, if you point me in the what's Laidley next to?
Sorry?
What's Laidley next? Yeah.
Oh, I don't even know. I just know it's in Queensland. I have a friend who I was talking to today, thinking about it for their son. I didn't know where to recommend for them.
Hang on. So
We can have a chat about it after the episode.
if Laidley's out towards, um, it's out towards Ipswich or out further than Ipswich, Springfield Lakes.
Springfield Lakes.
Yeah, there's a new TMS clinic in Springfield Lakes.
Okay.
Oh,
sweet.
nice one.
Awesome.
So out towards Ipswich.
So if you're listening out there, Shelley, there you go. If not, I'll tell you later.
There's one out there. Yeah, but there's, if you get a GP referral, there's a GP TMS clinic should be able to take, even if you get a GP referral to any TMS clinic, and you go and look up and you're like, oh, one's closer. You should just be able to send that one to the one that's closer, even if it's got a different name on it or anything.
Cool.
TMS clinic should be able to take that. Yeah.
Awesome. Well, thanks heaps for that, Dan.
Thanks,
really
Dan.
appreciate it. Again, anyone listening, it changed my life. I cannot recommend it highly enough. Yeah, thanks, Dan, for everything and for coming on. I'm sure we'll have another chat a little bit more in depth, maybe down the road. I'd like to hear more success stories, about the business and how it's growing and people you're helping. That'd be great.
Yeah. I mean, like I said before, I just love hearing success stories like yours. Sometimes I even get emotional. Some people write things in cards and stuff, and I'm not an emotional person. I spend a lot of time, obviously, giving people bad news in hospitals. You become fairly fairly hardened towards being an emotional person. But yeah, it really does genuinely make us feel great. And I love reading the reviews on, when we see Google. I ask for staff. I say, if you're having a bad day, go read the Google reviews and see what difference you're making in people's lives, because it's so awesome to hear. Yep. Thank you for having me on.
I feel free finally. Like I'm living my life. I'm not surviving. I'm living my life. So I hope many more people get to experience this. Okay. Well, thanks everybody.
Cheers.
Yeah. Thanks, Dan.
Thanks,
John.
Dan.
Thanks,
we will get you to stay on, Dan.
Okay.
I'll try. Yeah. We're just gonna end the episode.
Yeah. Sure.
Goodbye, people.
See you guys.
Goodbye. Thanks, guys.